Greetings. Let us talk about endoscopic resection of a cecal polyp that goes on the inner side of the cecum, or the so-called medial wall, and extends all the way to the outer edge of the lip of the ileocecal valve. It looks like when my colleague who referred this patient to me felt that this was a very difficult polyp to find and placed a tattoo and took several biopsies, which turned out to be tubular adenoma. I was a little bit worried whether this lesion will lift well given prior injection of tattoo and multiple biopsies. That was my concern. So we performed this procedure under general anesthesia. Intubation to the cecum was a little bit technically challenging with multiple loops that were reduced. At one time, I was already up to 100 centimeters and barely reached the transverse colon. And after loop reduction, I was able to reach the cecum. Here, I'm injecting on the distal edge of the polyp using saline with indigo carmine. As you can see, we are using dynamic injection with a good lift. However, the lift was not satisfactory and require further injection on the lateral side. And compared to the previous one, this was a little bit superficial. As you can see, the mound, and then there is a valley in between the two injections. So you make sure that you obliterate that valley with a further injection so that when you use the snare will sit in nicely for your resection. In terms of the snare selection, you can try 15 millimeter snare or 10 millimeter snare. And whenever I have a cecal polyp, even though it takes a little longer, I try to use a 10 millimeter snare to avoid the risk of any complications. So here we used a 10 millimeter snare, and the electrosurgery setup was the old Irby machine with endocut Q, effect 3, duration 1, interval 3, endocut Q 3, 1, 3. And interestingly, when I tried to apply the current by using the yellow pedal, it did not work. So we had to actually reboot the electrosurgery unit and then cut it again. And this happened with every resection. We had to reboot. It took a longer time because of the rebooting of the electrosurgery unit, and we couldn't figure out why that was happening, and we had to mark that electrosurgery unit and send it for repair. So you could have cut from the previous cut, but instead I felt that I should cut the other side so that I could get a nice cut, and then the central portion will come out nice and easy. So here we are using again 10 millimeter snare, endocut Q 313. Fortunately, there was no bleeding, and the resection depth was satisfactory. Question is whether we reached the submucosa or not. We will discuss it a little bit later, and the importance of including the submucosa in your resection, especially in patients with tubular adenoma. So now, after resecting on either side of this polyp, we use the snare to remove the central portion of the polyp, again using endocut Q 313. So we are happy that the resection went well without any bleeding. As you can see, there was no bleeding, and distally you can see the tattoo, And there's a little bit of tissue at that top end, and we use the endocut I, effect 1, duration 3, interval 3 to remove that small area using the hot biopsy forceps for hot biopsy evulsion technique. Towards the IC valve, it's hard to figure out whether you have removed that polyp or not, and it is a good idea to clear as much of that area as possible to avoid recurrence down the road. So for this, I used the hot biopsy evulsion technique and tried to remove. As you can see, my hot biopsy was touching. So instead of applying a lot more current, I almost used a combination of hot biopsy plus cold biopsy, more of the cold biopsy for removal of this area. So we went ahead and removed some more of that central bridge because it's important to make sure that you not only have a clear lateral margin, but also a clear deep margin. Deep margin, I mean the depth should be below muscularis mucosa. And if you leave the muscularis mucosa, there is a possibility that you may end up with recurrence. And here is the muscularis mucosa bridge that you see. And we wanted to get rid of this. Snare will not work. In this case, the best thing is to use a hot biopsy, lift it, and tap on the yellow pedal, and it will come out nicely. As you can see here, now we can see nice submucosa. Whenever there is a doubt, in order for you to have a recurrence-free type of resection, take out some more of that tissue that is doubtful using hot biopsy evulsion or by using a snare resection. So I find that hot biopsy is very useful to remove small areas if there is any doubt. So we went on and cleaned the edge. Now the base, look at the base looks good. And now you take pictures. I take routinely pictures of the resection base and resection edges to have a documentation that I have actually completely removed all visible polyp. So it also helps you when you follow up these patients in terms of the recurrence for your own self-directed learning based on your procedures and reflecting on what happened. And unless you record, best thing is record videos and review like I'm doing. It is a good idea to have multiple pictures. Typically for my EMR, I will have at least 30 to 40 images. Even in this one, we actually placed 30 to 40 images as part of my endoscopy record. Then the ablation of the edge should be routinely done after any EMR procedure. Dr. Michael Burke from Australia has shown elegantly that you could get very good results with snare tip soft coagulation. In our own practice, we started way back in 2008, long before anybody used ablation of the technique, using APC, forced APC, set at 0.8 liters flow and 35 watts. And we have shown that using this technique in our practice, we have very low recurrence rate, about 3 to 4%, long before anybody appreciated the benefit of ablation of the edge. And as part of that protocol, I continue to use the same technique of ablation. But you will notice that when I'm ablating to the point of total mucosal injury. You can see the dark brown appearance. It's not just a white appearance. but dark brown appearance of the edge, and just the visible normal looking edge. Whatever amount of polyp that was residual there, we have already removed with the help of heart biopsy evulsion. And in addition to ablating the edge, I also do something different. And let us see, here we completed the top and the left margin, and now coming along the right margin. And you'll notice that my ablations go as I'm pulling my scope back. And that's the best way to ablate any edge rather than pushing the scope forwards. So as you're gently pulling back, you'll have a very controlled ablation. This will happen only when you know how to reach the cecum with a very short straight scope, so that you have a millimeter by millimeter control of the scope, and you have to reduce all the loops before you attempt an EMR. So in this case, I was mentioning before we reached the transverse colon, we already had 100 centimeters of the scope inside, and we had to reduce multiple loops so that we could reach the cecum by about 80 centimeters, 70 to 80 centimeters. And in addition to ablating the edge, I'm also ablating the base wherever there was any doubt of overlapping edge of resection. This closure is technically one of the most difficult closure, especially close to the IC valve, because the IC valve has a lot of fat, and the mucosa cannot be moved easily, unlike in other portions of the colon. And this is also difficult because the defect is towards the right side of the field, and those defects are much harder because your devices are coming parallel to that defect for closure. So I decided to use the Boston Scientific Mantis clip with the jaws, so that I could actually make a little bit of a mucosal anchoring with the claws of the Mantis clip, and allow me to close the defect. So you can see that I'm making very, very small moves with the cecum relatively decompressed, and be able to bring the edges together as I close the clip. Something to keep in mind, because every defect closure involves for you to think through how you're going to close. And we decided to close with the first two clips, and now the defect becomes smaller, and then we apply the third Mantis clip for a nice closure. And there is a little bit of a gap between this and the previous clip. You notice that. So that is something to keep in mind, because you have to constantly keep thinking how your procedure went. And I wanted to place the clip in between those two, between the second and third clip. I could not do that because of technical reasons. So I decided to close the lower end. So leaving a little bit of a gap made me worry that there is a possibility for bleeding. Hence, I decided to put Purostat as an additional protective mechanism. I've not done this before, but in this case, I felt that it is safer to take that additional step of applying a little bit of Purostat in between those two clips. So that's what we are trying to do here, to make sure that the area is well protected from the hemostasis point of view. So you have seen a complex case from the point of EMR. I'm going to put this patient on liquid diet for a couple of days, low residue diet for day 3 and day 4, and then regular diet on day 5. And we are going to bring this patient back in 6 months. So all these small things are important, and as you can see, very fine movements, and this you could accomplish if you learn during your screening colonoscopy how to reach the cecum with the shortest possible scope. Aim to reach the cecum between 60 to 80 centimeters. Larger people, maybe 80 centimeters, smaller people by about 60 centimeters. On average, 70 centimeters. We use the net, and when you're taking it out, be careful not to catch a clip in the mesh of the net. That is one precaution you should take. Thank you.